Good morning, sir.
Good morning.
Sir, presenting a case, 42-year male who was admitted to us with a complaint of pain in abdomen and abdominal fullness since 6 months, early satiety and decreased food intake since 2 months. So he gave significant weight loss, history of weight loss, more than 10 kgs since last 2 months.
So abdominal pain,
Yes, sir.
fullness of abdomen,
Yes, sir.
and decreased satiety
Yes, sir.
and weight loss.
Yes, sir.
Okay.
So the pain was dull, dragging type in the left side of the abdomen and was aggravated on lying towards right lateral position.
Okay, when the patient was getting right lateral, it
Sir,
was aggravating.
yes, sir.
And it was a dragging pain.
Yes, sir.
Along with fullness on the left side of the abdomen.
Yes, sir.
Okay.
Sir, he gave no history of fever, vomiting or loose stool, no history of melena, hematochezia or hematemesis, no history of chest pain, no history of shortness of breath, no history of edema feet, no history of recent travel, no history of alcohol intake, and no history of high risk behavior.
Okay.
Sir, on examination,
So before going to examination, what can be the possibilities? So the patient is first complaining of a left-sided abdominal pain
Yes, sir.
over a period of 6 months,
Yes, sir.
and along with sense of fullness and early satiety, and it's a dragging type of pain you said,
Yes, sir.
and the pain was aggravating especially when the patient was lying on the opposite side, that is right lateral side.
Yes, sir.
So looking at this scenario, we are maybe we are dealing with some lump in the abdomen, because that is not a generalized distension,
Yes, sir.
and the pain he could bear the pain over a period of 6 months is a dragging type of pain,
Yes.
and causing early satiety means there is some compressive symptoms maybe, because there is by taking little amount of food the patient is feeling I am full.
Yes, sir.
Okay, all these things can lead to a possibility of a mass or lump in the abdomen, that too in the left side. Okay, let us see. There is other no history of hematochezia, melena.
Yes, sir.
Okay. But weight loss history is significant.
Yes, more
this
than
is
10
important.
kgs.
This is important because there is weight loss.
Yes, sir.
Okay, either there is any systemic process associated with this pathology, or else because of early satiety, the food intake has been decreased, and that has may led to the weight loss. Okay, on a general examination, what are your findings?
So on general examination, BP was 110/70, pulse rate was 82, it was regular. And sir, on further abdominal examination, rest all systems were normal. On per abdominal,
There is no pallor.
Sir, pallor was present.
Okay, present the general examination findings, yes.
Pallor present, no icterus, no cyanosis, no lymphadenopathy present, sir. Edema mild grade on lower limbs present, sir. No clubbing present.
No clubbing present, edema. What was JVP?
Sir, JVP was normal.
JVP is normal. Okay. On abdomen examination?
So on abdominal examination, there was massive splenomegaly beyond the umbilicus.
Okay, there is massive splenomegaly, you
Yes.
said? Let us see. So yes, on superficial palpation, there is no guarding rigidity tenderness. On deep palpation, लंबी सांस लेंगे, लेते जाइए, छोड़ते जाइए, लेते जाइए, छोड़ते जाइए, लेते जाइए, छोड़ते जाइए. ओके, लंबी सांस. यस यस. सो ओके, ठीक है. So here I am palpating. There is a lump
Yes, sir.
in the left upper quadrant involving the left lumbar area. Iliac is empty, the lumbar area, and it is coming down like this, extending the umbilicus beyond the midline here. लंबी सांस लो, छोड़ो. Yes, the lump is moving well with respiration. It is moving well with respiration. I cannot get above the lump. I cannot insinuate my finger between the lump and the left costal margin. Lower border of the lump is palpable, and it is moving with respiration. I can feel the distinct notch on the lump. This is a spleen. So this confirms this lump is a spleen. So you have measured this splenomegaly?
Yes, I have measured this splenomegaly. Sir,
How much is the spleen?
sir, it is 19 centimeter.
Can you demonstrate how did you measure it?
Yes, sir. Sir, so first we have to locate from where and where to measure. First, the sternal notch, the sternoclavicular joint, then the acromioclavicular joint. We taking a midpoint.
Where is the sternoclavicular joint? This is the sternoclavicular joint.
Sir, this is the sternoclavicular
This
joint.
is the
acromioclavicular joint.
This is the midpoint you have
Sir,
taken.
midpoint,
There is the
midclavicular
line.
Yes,
okay.
sir. So then tracing a parallel line to the sternum, we take it to the sternal border, lower sternal border. The whole lower sternal border is traced.
So from the midclavicular line, we have drawn a parallel line running parallel to the sternum, and it is meeting the costal margin. Then what
So
did you
from
do?
this intersection,
Ah.
where the lump is most felt, the outermost part of the lump.
Outermost part of the palpable part of the spleen.
Yes, sir.
Okay.
From that point to the most palpable part, outermost palpable part.
Most lengthiest, most outermost palpable part. Yes, let
We'll
us
measure it.
measure it.
So from this point, extending up to this point, we have 18.5 centimeters.
It's approximately 19 centimeter. Okay.
Yes, sir.
So this is a massive spleen.
Yes, sir.
Okay. So this spleen you measure, it is 19 centimeters.
Yes.
So it is massive splenomegaly.
Yes, sir.
Can you define what is a massive splenomegaly?
Sir, when we measure, there is any spleen size from costal margin beyond 8 centimeter.
So
Yes,
massive
sir.
splenomegaly is palpable spleen more than 8 centimeter below the costal margin. So it is way beyond 8 centimeter. It was massive splenomegaly. So looking at this massive splenomegaly and other abdominal findings, there was no free fluid also in the abdomen. Retrospectively, when you go back to the general examination, do you want to add something in the general examination?
Yes, sir.
Retrospective thinking, massive splenomegaly, you have already presented general examination. Can we reinforce our general examination with repeating some important things that should be repeated,
Yes.
and adding some things going back after this spleen?
Yes, sir. Sir, I would like to reconfirm that pallor was present.
Okay, pallor was present. Okay, jeep दिखाइए.
Sir, icterus absent.
Okay.
No cervical lymphadenopathy.
So there is no lymphadenopathy. Okay.
No, sir. Sir, no sternal tenderness present.
Okay. Okay.
Sir, then we'll look for oral cavity.
Is there any clubbing?
Sir, no signs of clubbing present. Sir, no softening of nail bed.
Okay, no clubbing present. Yes. Oral cavity.
So then in the oral cavity, we will look for any mucositis or any opportunistic infections or any signs of gum bleeding.
Okay, bleeding, mucositis, opportunistic infection. Okay.
Yes, sir. Sir, followed by we look for petechial rash in the lower limbs.
No petechiae in the lower limbs.
Yes, sir.
Okay. Why did you go for oral cavity examination with all these findings? You wanted to portray mucositis, opportunistic infection.
Sir, look for any signs of liver cell failure.
No, actually it is leukocytosis. So actually what we are speaking now is a massive spleen.
Yes, sir.
So this can
WBC count.
WBC count, platelet count, hemoglobin can itself be decreased by a massive spleen. The term you know is hypersplenism.
Yes, sir.
So these things should be searched for. Plus hematological conditions that cause massive splenomegaly, like leukemias, they can present with these opportunistic infections, bleeding diathesis, like palatal thrombocytopenia. So all these cell lines are important when you discuss a massive spleen, because spleen eats up all these cell lines. Phagocytosis. Okay. So these things to be seen. Okay.
So then we look for the signs of chronic liver disease.
Okay. Signs of chronic liver disease. Why did you look for? Because we are thinking of
So
portal hypertension. Okay. Absence of chronic liver disease signs.
Yes.
No icterus.
No problem.
Okay. No dupuytren's contracture, palmar erythema, no free fluid, and okay. No signs of gynecomastia. No gynecomastia.
No, sir.
Okay. So all signs of liver cell failure is absent.
Absent, sir.
Okay, now that we have seen our case of massive splenomegaly, now let us see what are the causes of massive splenomegaly. This will be our differential diagnosis. Then we will investigate the patient. After receiving the investigations, we will further go ahead with the differential diagnosis, ruling in and ruling out certain conditions, and we will try to diagnose what was the cause of massive splenomegaly in our case. So when we go for causes of massive splenomegaly, infectious causes, that is malaria. In malaria, It is also known as tropical splenomegaly syndrome or hyperreactive malaria syndrome. What is this? Actually, it is not like that. Today or tomorrow, suddenly I will have fever with chills, and the peripheral smear will show gametes, and malarial positive, antigen positive will happen, and the day after I will have a massive splenomegaly. This is not at all the scenario. What happens in malaria is, this is especially seen in malarial endemic zones where people are having an endemicity of malarial infections. Lot of population has undergone or they have suffered from recurrent attacks of malaria, and these recurrent attacks of malaria over a period of time has created a immunogenic reaction, and this immunologic reaction has caused the massive splenomegaly. That is why it is known as hyperreactive malaria syndrome. It presents really as massive splenomegaly. Second is visceral leishmaniasis or Kala Azar. So it is usually endemic, or these cases are more seen in our country, in Bihar. So this is Maharashtra. Okay. Now other causes are massive splenomegaly. If I take a GIT cause, it is portal hypertension. So whether it is a cirrhotic portal hypertension or non-cirrhotic portal hypertension, in those situations portal hypertension can cause massive splenomegaly. Coming to hematological causes of massive splenomegaly, first will be chronic myeloid leukemia. Second will be myelofibrosis or myeloid metaplasia. As you know, these are myeloproliferative disorders. CML, myelofibrosis, polycythemia rubra vera, primary polycythemia may cause massive splenomegaly, though it 100% causes moderate splenomegaly, but it can present as massive splenomegaly. Essential thrombocythemia can also cause massive splenomegaly, and certain lymphomas like hairy cell leukemia and especially the pro-lymphocytic chronic lymphatic leukemia can present as massive splenomegaly, and thalassemia major. Okay. Coming to storage disorders, Gaucher's disease, Niemann-Pick disease, mucopolysaccharidosis, these storage disorders can cause massive splenomegaly. Looking at our patient at this point of time, I would rule out storage disorders. Those disorders usually present in the pediatric age group, so we will not include those things in differential diagnosis. So this will be our main differential diagnosis in a case of massive splenomegaly. Now we have investigated the patient, and let us see what are the investigations reports. Okay, so we have investigated the patient.
Yes, sir.
So can you please first tell me what was the peripheral smear report?
Sir, the peripheral smear was suggestive of
Little bit louder.
The peripheral smear was suggestive of pancytopenia with no blastings.
Okay, the peripheral smear suggested pancytopenia.
Yes, sir.
Okay, can you read it out? What are the other things? Was there any blast cells?
Sir, no blastings in the peripheral smear.
No blasts.
Normocytic, normochromic.
Normocytic, normochromic, no blast were seen.
Yes, sir.
So peripheral blood was pancytopenic. What was the hemoglobin level?
Sir, hemoglobin level was 7.9 grams.
Hemoglobin 7.9 gram. What was the absolute neutrophil count?
Sir, 900.
Absolute neutrophil count was 900. Pretty bad. Okay, then.
Sir, MCV was
Absolute
80.
platelet count?
Absolute platelet count was 50,000.
Absolute platelet count was
50,000.
50,000. So obviously it is a pancytopenic picture.
Yes.
Okay. Bone marrow we have done.
Yes, sir. We have done bone marrow. It was suggestive of hypercellular marrow, sir, with megaloblastic maturation.
Hypercellular marrow. So interesting. Now this patient with massive splenomegaly is having pancytopenia and a hypercellular marrow.
So we also
Okay.
did.
What is the MCV?
So MCV was 80.
MCV 80, if we see MCV 80, it is pretty normal.
Yes, sir.
It's not actually a megaloblastoid picture, but marrow is hypercellular. Okay. Okay. Any abnormal cells they have commented
No, sir.
on the peripheral smear?
No, sir.
Any shift to left, abnormal erythrocytes in the bone marrow? Are they seeing any abnormal erythrocytes?
No, sir.
Nucleated RBCs? No nucleated RBCs.
Yes.
Hyposegmented neutrophils?
No, sir.
Low granular platelets?
No, sir.
Nothing. So now that we have received the reports, and our patient is having pancytopenia with hypercellular marrow. So let us, for the time being, let us forget this massive splenomegaly part. And as a learning process, let us see if any patient presents with pancytopenia with hypercellular marrow on bone marrow examination. What are the conditions we should entertain? These are the conditions: differential diagnosis of pancytopenia with a hypercellular or cellular marrow. So some primary marrow disorders like myelofibrosis, paroxysmal nocturnal hemoglobinuria, myelodysplastic syndromes, myelophthisis, lymphomas like hairy cell leukemia. These are the primary bone marrow disorders that can cause pancytopenia with a cellular marrow. There are some acquired conditions like infections, especially tuberculosis, HIV, chronic HIV infection, tuberculosis, sarcoidosis, brucellosis, leishmaniasis, and sepsis. Vitamin B12, folate deficiency, and sometimes copper deficiency can cause pancytopenia with a cellular marrow. And lastly, autoimmune conditions like SLE. Okay. Now, with this differential diagnosis, let us now bring in our patient scenario, massive splenomegaly. Before that, let me write another most important thing that should not be forgotten about this acquired condition is hypersplenism. Itself, the large spleen, the enlarged spleen, as you know, it is a go down of phagocytosis. This spleen, when it is activated, such a large spleen starts to phagocytize all the RBCs, WBCs, platelets. That leads to pancytopenia. So hypersplenism itself will lead to pancytopenia with a cellular marrow. So when I bring in massive splenomegaly with this scenario, what are the conditions I am ruling out? Okay. What about myelofibrosis? It is a known cause of massive splenomegaly. So this is in. Myelofibrosis is in. Paroxysmal nocturnal hemoglobinuria, myelodysplastic syndrome usually do not cause massive splenomegaly. And had it been a myelodysplastic syndrome, then the bone marrow would have suggested the presence of blast. And in the bone marrow, there are always cytopenias with abnormal cells. Again, shift to left, abnormal leukocytes, hypogranular hyposegmented neutrophils, platelets with low number of granules, sometimes giant platelets, and abnormal morphologic RBCs. This is not present in the bone marrow. Plus, this syndrome doesn't present as massive splenomegaly. So, PNH is another condition. Patient presents with pancytopenia. There is history of occasional early morning hematuриas, and usually they present with venous thrombosis and visceral thrombosis, venous thrombosis, arterial thrombosis. We are not usually females, younger age group. We are not thinking of this now. MDS we have ruled out. What about myelofibrosis? Again, myelofibrosis, had it been myelofibrosis, the bone marrow picture would have shown us leukoerythroblastic blood picture. So what do you mean by leukoerythroblastic blood picture? Means again there is a shift to left. There is nucleated RBCs, giant metabolocytes, abnormal platelets, and this should have been picked up in the bone marrow. So we are not considering, even if there is a massive splenomegaly, looking at the blood picture and the bone marrow picture, myelofibrosis is not a likely possibility. These two are not likely possibilities. Coming to myelophthisis, what is myelophthisis is infiltration of epithelial malignant cells into the bone marrow causing a bone marrow fibrosis. So especially malignancies of the lung, prostate, malignancy of the prostate, lung, breast, sometimes neuroblastomas. These are usually the malignancies that infiltrate into the bone marrow causing marrow fibrosis. There is no evidence of all of these things. So this is out in our patient. Some lymphomas and hairy cell leukemia, very characteristic as the name suggests, in the bone marrow or peripheral blood, the cells abnormal leukemic cells, they have projections, hair-like projections on the cells. That is why this is a hairy cell leukemia. The peripheral smear is not showing all these things. So maybe our patient is not suffering from a primary disorder affecting and causing marrow failure. Coming to the acquired conditions, HIV was negative. This is HIV negative. We have done triple H.
Yes, sir.
So hepatitis and HIV are negative. We have already done a MAR2 test which was negative, and the X-ray picture was clear. So we are not thinking of tuberculosis. There was no lymphadenopathy as you presented in the clinical examination. There are no stigmata of tuberculosis, no lymphadenopathy. X-ray chest is normal, and tuberculosis we are ruling out. Sarcoidosis, brucellosis, leishmaniasis we have taken into consideration. Not a disease in this part of the India, that is Maharashtra. Sepsis, there is no abnormal cell, no fever. Pancytopenia can be a presentation of sepsis, but again see there are no whole bodies, toxic granules, so we are ruling out sepsis. And vitamin B12, folate, copper usually do not present with massive splenomegaly. We are not considering these things. Still we had sent the vitamin B12 level which was normal in this case. Autoimmune disorders, ANA was negative in our case. We are not thinking of SLE. Again, do not present as massive splenomegaly. So usually these conditions do not present as massive splenomegaly. Coming down to the last, that is hypersplenism. If I consider hypersplenism, what is the cause? Is it a portal hypertension? Is it a portal hypertension? Thinking this, we further investigated our patient. So we did an upper GI endoscopy. Can you read the upper GI endoscopy report?
Sir, upper GI endoscopy was done. It was suggestive of esophageal varices.
So esophageal varices were present. Esophageal varices were present.
Yes, sir.
So it confirms portal hypertension. Varices confirm portal hypertension. Okay. Now once it is portal hypertension, our dichotomy starts, whether it is cirrhotic or non-cirrhotic. We have done the CT scan. USG was pretty suggestive of portal venous hypertension. Liver was normal in USG. We further went ahead in the CT scan. What does the CT scan
show? We did
CCT?
CT abdo-pelvis, which was suggestive of portosplenic collaterals.
Portosplenic collaterals. Portosplenic collaterals.
And the normal liver, parenchyma.
Liver normal. Liver normal. We went ahead with the fibroscan.
Yes, sir.
Fibroscan was negative.
So fibroscan was negative.
Fibroscan was negative for fibrosis or nodules. So with portosplenic collaterals and normal liver, probably we are dealing with a case of non-cirrhotic portal hypertension. So the final diagnosis in our case was a non-cirrhotic portal hypertension, non-cirrhotic portal fibrosis, sometimes known as non-cirrhotic portal hypertension, extra hepatic portal venous obstructions, schistosomiasis, all these conditions come into account when we talk of this. When we talk of extrahepatic portal venous obstruction, splenic portal vein thrombosis. USG is not showing, CT is not showing any splenic vein thrombosis, portal vein thrombosis. Extrahepatic portal hypertension is less likely. So maybe we are dealing with a idiopathic non-cirrhotic portal hypertension. The final possibility in our case was a idiopathic non-cirrhotic portal hypertension. So this is in nutshell. We discussed the clinical examination in a case of massive splenomegaly. What are the physical examinations we should do, ruling out certain conditions. We have to go for the investigations. What are the causes of massive splenomegaly? So in this case, after investigation, we concluded that our patient had pancytopenia, hypercellular marrow. As a learning process, we discussed what are the causes of pancytopenia with a hypercellular marrow. Now, including our case, massive splenomegaly, pancytopenia, hypercellular marrow. Finally, what things we considered? How did we rule out all those conditions with all again going through the investigation reports? And finally, this was an interesting case of non-cirrhotic portal hypertension. Thank you.